Dear friends and colleagues, it is for me a pleasure to be speaking once more in this annual conference of the Bulgarian Society for Dermatologic Surgery. I'd like to thank the organization, in particular Professor Georgi Chernev, for inviting me again. For this first lecture, I chose this topic, atypical fibroxanthoma and pleomorphic dermal sarcoma, which are two closely related entities, at least from a morphological point of view on histology, and they can pose a significant diagnostic and therapeutic challenge. Atypical fibroxanthoma is a relatively rare mesenchymal neoplasm. The histogenesis is still debated, is probably fibrohistiocytic or fibrocytic or even myofibrocytic, and it is characterized by marked cytological atypia with lots of bizarre cells and atypical mitosis. But if we apply strict diagnostic criteria, in fact most cases, despite this very malignant histology, they will have an essentially benign behavior, with rare cases showing local recurrence. The relationship with pleomorphic dermal sarcoma is somewhat debated. They appear to be probably extremes of the same spectrum or even the same entity with different depth and different capacity of invasion. And some say that there is a possibility of transformation of atypical fibroxanthoma into pleomorphic dermal sarcoma. Starting with atypical fibroxanthoma, clinically, usually the features are non-specific. It typically presents with an exophytic nodule. Most cases have less than 2 centimeters in diameter. They are typically well defined and they have very rapid growth with frequent ulceration. They occur mostly in sun-exposed areas, and there is a predilection for the head and neck in elderly patients with a predilection for male patients. Histologically, this is the prototypical presentation of atypical fibroxanthoma. We can see a superficial dermal neoplasm, well defined and partially surrounded by a epidermal collarette. Cytology is usually characterized by an admixture of epithelioid and spindle-shaped cells with this very marked pleomorphism and cytological atypia. Here we can see this admixture of spindle-shaped cells and epithelioid cells with lots of pleomorphism, including multinucleated giant cells and also mitotic figures. There are, however, many variants, usually from the cytological point of view. This is a peculiar variant, which is so-called spindle cell non-pleomorphic atypical fibroxanthoma. So this is a variant characterized by a lesser degree of pleomorphism, as you can see here. So there are fascicles of spindle-shaped cells with mitotic activity, but pleomorphism is not marked, unlike what happens with other variants. Here we can see a clear cell variant, here with predominance of epithelioid cells with some bizarre cells and multinucleated giant cells. This is a pigmented variant. The pigment is usually a hemosiderin and results from hemorrhage within the tumor. This is a myxoid variant, which we can see this very clear stroma of the lesion. And this is an example of a variant with osteoclast giant cells. And there are even other variants, including granular cell, AFX, etc. This particular variant relates to the stroma, so this is a keloidal variant of AFX. So this is characterized by the presence of these very eosinophilic and thick hyaline bundles of collagen in between the neoplastic cells. So we can see that there is a high variability in the morphology of the cells that compose AFX. And so the immunohistochemistry is mandatory for the diagnosis. AFX is a diagnosis of exclusion, and there are no specific markers. So AFX can be variably positive for a lot of these markers that are listed here. The most common ones are CD10, CD68, CD99, but to some extent they can be positive to many of these markers, including smooth muscle actin, EMA, P63, which is usually very focal, procollagen 1, factor 13A, microphthalmia transcription factor, which is mostly a melanocytic marker, and also these two melanocytic markers can be positive, melan A and HMB45, but usually only in multinucleated giant cells. And also S100 can be positive, but only in dendritic cells. This can be a diagnostic pitfall, especially in tumors that contain lots of reactive histiocytes with dendritic morphology that may stain with S100. So it is very important to be aware of pitfalls, especially in partial biopsies and without immunohistochemistry. So this is an example of atypical fibroxanthoma, positive for CD10 and P53. Here we can see a morphologically similar tumor with this nodular morphology, relatively well circumscribed, with a similar pleomorphism to AFX, but in this case the tumor is positive for AE1, AE3, which is a pankeratin, so this is a poorly differentiated squamous cell carcinoma, which is one of the differential diagnoses. Here we can see a similar tumor, also nodular, relatively well circumscribed, composed predominantly of spindle-shaped cells with pleomorphism, but in this case the neoplasm is diffusely positive for S100, so this is a melanoma. So the differential diagnosis includes, from a cytological point of view, mainly these two neoplasms that are listed here, melanoma and sarcomatoid spindle cell squamous cell carcinoma. And in some instances, more rarely, we can also make a differential diagnosis with leiomyosarcoma and angiosarcoma. So for melanoma, melanocytic markers are useful. We usually use S100 as an initial panel to study lesions that resemble AFX, but in some cases we may also use HMB45, melan A, or SOX10. For the diagnosis of sarcomatoid squamous cell carcinoma, we should use these keratin cocktails like A1, A3, and MNF116, but I find particularly useful cytokeratins 5 and 6, P63 or P40. For the diagnosis of leiomyosarcoma, desmin and H-cal-desmin are important, and in the few cases in which there may be a problem diagnosing AFX, in which it may be confused with angiosarcoma, it would be useful to use these vascular markers like ERG and CD31, but this in fact is usually a minority of cases. The distinction between AFX and pleomorphic dermal sarcoma cannot be made on immunohistochemistry or on the cytological features. It depends on the architecture of the lesion and in other features that we can see here. So pleomorphic dermal sarcoma has the same type of cells as AFX, but is usually a more asymmetric lesion with deep invasion to the subcutaneous tissue and sometimes even deeper tissues, and shows necrosis and vascular or perineural invasion. So these are the features that allow distinction from atypical fibroxanthoma. And these features can only be assessed in most cases in excision specimens. So we should not do a definitive diagnosis of AFX just based on a small partial biopsy. So here we see a case of pleomorphic dermal sarcoma. As we can see on the surface, it may look very similar to atypical fibroxanthoma. It is partially polypoid, it's ulcerated, and it has a little bit of an epidermal collarette around, but as you can see here, is asymmetric and deeply infiltrative, going through the subcutaneous tissue. And here we see features that can also be present in pleomorphic dermal sarcoma, including necrosis that we can see here, perineural invasion, and also vascular invasion. Regarding prognosis, the distinction between these two entities is important because they are different in terms of prognosis. Atypical fibroxanthoma, if we apply these strict diagnostic criteria, which means we should only diagnose it when it is a superficial tumor, symmetric, without deep invasion, without necrosis, and without vascular or perineural invasion. In these cases, if we apply strict diagnostic criteria, most cases will have benign behavior. So there is a rare possibility of local recurrence, and metastases are exceptional. So there is a bias in the literature. It was thought to be a more aggressive tumor, but this was in older studies before the generalized use of immunohistochemistry. For pleomorphic dermal sarcoma, which is even rarer than atypical fibroxanthoma, there are few studies, and however, more accurate diagnostic criteria have been delineated more recently. So in this study by Thomas Brenn and his co-authors, with a mean follow-up of 24 months, the cases of pleomorphic dermal sarcoma showed a significant rate of recurrence of 28%, with metastases in 10% of the cases. Most of them were cutaneous and rarely for lymph nodes. However, in their study, there was no specific mortality associated with the disease. Regarding treatment, the treatment for atypical fibroxanthoma is usually surgical excision with free margins. The excision margin is not standardized. There are some case reports of the utility of using Mohs surgery, probably in selected cases. For pleomorphic dermal sarcoma, usually we should be a bit more aggressive with a wider excision. However, the excision margins are also not well defined. And there is also a big question mark here for adjuvant therapy. So there are some cases in which radiotherapy has been used, mostly as adjuvant modality, especially in unresectable disease, in cases in which there is involvement of surgical margins, in cases of metastasis also. However, there are no standardized protocols. Here I show you to finish my lecture, I'll show you a small study that we are conducting recently in our department in Coimbra. It is a retrospective study of cases of AFX and PDS. So this study is looking back at cases from a period of 10 years, from 2009 to 2018. And we collected 23 cases, so this is a rare, these are relatively rare neoplasms, so we collected 23 cases, there are not many. The whole group comprises 14 male patients and 9 female patients. Atypical fibroxanthoma was more common with 15 cases versus 7 cases of pleomorphic dermal sarcoma and 1 case that was not classifiable because it had only an incisional biopsy. So the mean age was over 80 years old, and the head and neck was by far the most common location with 22 cases. All the cases were positive for vimentin and or CD10, but they were negative for other lineage specific markers like melanocytic markers, keratins, etc. So by definition, these cases should be negative for these lineage specific markers. And these were the main differences that we found. AFX had a mean size of 18 millimeters versus 28 millimeters for PDS. They are larger. The tip margin was involved in 4 cases of AFX. However, there was only 1 recurrence and no cases of metastasis. On the other hand, in cases of PDS, although there was only 1 case with a positive dip margin, we could see 2 cases of recurrence and 2 cases of metastasis. One of them only for lymph nodes, and the other one with distant metastasis in which the patient died of the disease. Interestingly, there was one of the cases that had borderline features between AFX and PDS, in which in the end we favored PDS. He developed lymph node metastasis, which was treated with surgery and adjuvant radiotherapy, and the patient did not develop further disease. So the patient is still alive without recurrence or metastasis after 4 to 5 years after the initial diagnosis. So these results are more or less in keeping with what we see in the literature. So pleomorphic dermal sarcoma behaving in a more aggressive way than AFX. So AFX and PDS appear to be part of a morphologic and probably biologic continuum. They are both diagnoses of exclusion. Definitive diagnosis requires immunohistochemistry and assessment of the whole lesion so that we can see the architecture and other associated features. And the treatment, it's not standardized. So excision is more or less of a consensual treatment option, and probably radiotherapy in some selected cases, and mostly as an adjuvant therapy. The prognosis of AFX is good with rare local recurrence, whereas PDS shows an intermediate prognosis with more frequent local recurrence and regional metastases. Distant metastases appear to be rare. I thank the colleagues who helped me with this work, and I thank you for your attention. Thank you very much.